for case number 3, we'll invite up Dr. Lara Rodriguez Sanchez, please.
Hello, everybody. First of all, thank you very much to the organizers for giving me the opportunity to present this clinical case. This is a 60-year-old man with no previous surgeries, hypertension, who reported moderate urinary symptoms, mild erectile dysfunction, and who was followed from 2016 for elevated PSA. So what happened from 2016 to date? Here we can see how the PSA fluctuated and that the patient had 2 MRIs in 2016 and 2020, and at that moment we didn't identify any lesion. But in 2024, with a PSA at 8.13, we decided to do a new MRI. And this is the new MRI. Here we can see a 8 millimeters lesion in the right posterolateral basal mid-region of the prostate that was classified as Pirates 4 without extracapsular extension, without lymph node involvement, and the prostate size was around 30 cc's. So we perform the systematic and target biopsies, and here we can see that we identified 2 positive biopsies at the level of the lesion that we saw on the MRI, both of them ISO3 with 70% of grade 4. So focal therapy for ISO3 prostate cancer, can we consider it? Well, according to the Falcon consensus, it was stated that focal therapy should be offered to patients with localized ISO3 prostate cancer. And here we can see that most of the participants agreed with the idea of treating this kind of patients, and consensus was reached during the face-to-face meeting. So with all this, I discussed with the patient the possibility to do a focal treatment, his doctor, and he agreed with this. So the next step was to get the green light from all my colleagues during the multidisciplinary committee. And this was a little bit tricky, because some misgivings, some concerns arose, like the lack of supporting evidence, the lymph node management, as well as the risk of understaging. So regarding the lack of supporting evidence, it has been said that we have to be careful when treating patients with ISO3, 4, and 5 prostate cancer. And it's true that there is not a lot of evidence. Before treating this patient, I conducted a narrative review just to know if it was a good idea or not, and I identified these papers that you can see here, and all of them are retrospective and included less than 20% of patients with ISO3 prostate cancer. In this first study, 600 patients were treated with HIFU, and less than 20% had an ISO3 prostate cancer. But ISO2 and ISO3 were considered together, so we cannot reach any conclusion to know if we can treat ISO3 prostate cancer patients or not. This second study, with more than 1,000 patients treated with HIFU, only 15% harbor an ISO3 prostate cancer, and it was observed that the retreatment-free survival was higher for those patients who had not an ISO3 prostate cancer. So we may conclude that we should avoid focal therapy for patients with ISO3 prostate cancer. Regarding this other study on MRI guide HIFU, half of patients with ISO3 prostate cancer had a recurrence, clinical significant prostate cancer recurrence at 2 years after treatment. So once again, we may conclude that we should not treat these patients. But here, in a series of 200 patients treated with IRE, 60% of patients harbor an ISO3 prostate cancer, and finally, no significant differences were observed in terms of failure-free survival. And what about the HIT registry? In this registry, in this study that included patients from the HIT registry, With more than 1,000 patients, 16% of patients with ISO3 prostate cancer, it was concluded that ISO3 prostate cancers were at higher risk of a failure than the patients with ISO1 and ISO2 prostate cancer. But if we look at the numbers, we can see that the difference are very, very small, 66% versus 65%, and the p-value was 0.05. So I would not say that we should not treat patients with ISO3 prostate cancer based on this study. And finally, in this study with cryotherapy, 160 patients were treated with 16% of ISO3 prostate cancer were treated with cryotherapy, and no significant differences were observed in terms of failure-free survival. So again, a positive answer. With all this, I discussed with my team the possibility to do a focal treatment. There is not a lot of evidence, but they agree with the idea, but then we had to discuss what to do with the lymph node management. And in this regard, the EAU did us a favor, because in the last prostate cancer guidelines, the lymph node dissection at the time of the radical prostatectomy is not even mentioned for intermediate risk prostate cancer patients, which means that the need to perform the lymphadenectomy is not longer an argument against focal therapy for intermediate risk prostate cancer. And finally, regarding the risk of understaging, it exists. This study has been presented several times during this conference, and it has been proved that the PSMA plus MRI improved the negative predictive value and the sensitivity for detecting clinical significant prostate cancer. And several systematic reviews and meta-analyses have been published on the role of the PSMA in the staging, in the prostate cancer staging. And generally speaking, we can say that multiparametric MRI is better for seminal vesicle invasion and extracapsular detection, and PSMA is better for lymph node detection. So the PSMA enhanced risk stratification by detecting hidden MRI lesions and identifying patients at risk of staging. So with this in hand, we decided to do a PSMA before performing the treatment. And here we can see how the lesion identified on the MRI is also visible on the PSMA. So finally, we got the green light, we performed the treatment, and here we can see the HIFU. I'm sorry, here. This side corresponds to the fusion image. This corresponds to the treatment itself. The treatment was performed with a focal one device. And regarding the follow-up, here we can see the previous MRI and the early postoperative MRI. For the moment, I always ask for an early postoperative MRI to have a feedback about the treatment. And here we can see the cavity after the HIFU treatment. So I had a phone consultation with this patient before coming to the conference 4 days ago, and the patient reported no changes in urinary symptoms, no changes in erectile function, but he reported an ejaculation that was not present before the treatment. Regarding the PSA results, they are pending because we wait for 3 months, and we have not conclusive conclusions as yet because the treatment was performed two months ago. But at the end of the day, if we want different results, we have to do different things and see if they work or not. Thank you very much.